So I was invited to present my work on success of medically necessary bilateral salpingo oophorectomy without uterine manipulator or urinary catheter. I'm aware this is a midwifery conference, midwifery and neonatal conference, but I think this is like quite closely related since it's in the field of gynecology, particularly pelvic laparoscopic surgery, particularly in the gynecological uh, structures. Um, so I try to be a bit more like the considerate to like the that I say like the that I find men in this field as well is that especially the transgender people. So that's what the patient in this paper is about, is a transgender person, and that to respect that that they identify as a man, that they're on testosterone, but they do have gynecological structures. So I, I know, trying to like use the right words. So I don't know. So I try my best. Um, right. So what happened here is this young male transgender patient who had continuous heavy bleeding despite testosterone treatment, which is testosterone treatment is supposed to suppress the heavy periods and estrogen production, but it seemed to be that the patient was struggling with the hormone levels and getting the hormones in the right ranges. So, and I think they saw several specialists to try and like how do you solve the issue of the heavy periods, and that it might indicated that there was endometriosis. But with the endometriosis, like it's not sufficient enough to just do like um, an ultrasound. The ultrasound doesn't reveal like give as much detail to um, the walls of the pelvis. So actually, they usually what they do like the diagnostic laparoscopy, but to minimize the amount of times that you like you perform a surgery on a patient, is that usually what they say is if there's some indication um, of endometriosis, and also that they require like some organs removed, is that they just kind of do all the diagnostic and treatment procedure all in one go, just to prevent going back into surgery. So that's what seemed to happen here, is that they suspected endometriosis, and then the patient also uh, like wanted the intervention, a surgical intervention to treat the heavy periods. Is that the theory was that if we remove the estrogen producing organs, then the periods will definitely cease, um, because they couldn't get the hormones in the right ranges. So yeah, there was a history of about, I don't know, like 4 years of hormones. I think initially the testosterone stopped the periods, but then the patient took a break from hormone replacement therapy and then went back on hormone replacement therapy, and then since then the periods just hadn't stopped. So then it was like, well, what solutions do we have for this? Obviously, usually surgery is like the last uh, it's a permanent decision, so it's the last resort. I think he tried a Vizon, some progesterone, but that seemed to exacerbate the condition. So after some discussion, yes, the patient didn't have any future intention of a pregnancy, so ovary removal was the appropriate solution in this case. um, so then this is what this paper mostly focuses on, is that the way that procedure, these pelvic procedures are performed, and what instruments are used, is that the ovaries are in the abdomen. It's not like the cervix. The cervix, they can't get to the cervix any other way but through the vaginal canal. uh Alternatively, like the ovaries are an abdomen, so it has nothing to do with the outside vagina or anything like that. So, but there's the issue was like the when you're in the um in the pelvis doing a laparoscopic surgery is that the issue seems to be the management of the uterus during the procedure. And so that's when some surgeons, but I see maybe a lot of surgeons in the field, that some insert an instrument in the vagina to manage the position of the uterus while inside the abdomen while performing laparoscopic surgery. But the patient was very adamant. Like, the patient was like, I do not want anything in my genitals. I'm very, like, I definitely need, like, it was a very sensitive matter for the patient. I think it is for a lot of patients with gynecological reproductive system, is that they don't be unnecessarily, I would say, invaded. So it was a journey that the patient had to see 3 surgeons, and it was a 3rd surgeon that said, you don't need to put anything there, and that we can do the procedure without it, and it doesn't increase the risk or anything like that. And considering the patient had no background in and never did a subject in medicine or surgery, so and these are most of the patients that are coming to these surgeons, are that they don't know that more about their gynecology than they do. So really they're vulnerable, and to take advantage of them to do something unnecessary is it's unprofessional, and it's not appropriate. So that's what this paper is very important about, because when the patient was doing some research before the procedure, he knew what procedure he wanted, but he did some like looking on the internet of how the actual procedure is done, and it seems to be not very well, like it seems like they don't tell you about it. It's there's not enough information out there clearing up that the facts of whether if it's needed or if it's not needed, because it can be a very complicated field, and there's different, like, this was just ovary removal, but there's hysterectomies and total hysterectomies, and there's different methods. And I find that's the case with surgery, that surgery is an art. There's different methods of treating the same condition, and it seems to be up to the surgeon and the abilities of the surgeon and the level of skill of the surgeon. But to me, that seems in gynecology, it seems like there's a lot of room for abuse and taking advantage of the patient. So that's where I wrote this paper based off this case, that it wasn't necessary, and that should set the benchmark for the rest of these operations, where like the law is written, where if it's not like any medically improper genital penetration is considered sexual intercourse, and sexual intercourse in a medical setting is illegal. The patient is consenting to a medical procedure. They're not consenting to sexual intercourse with the doctor. So it was a very distressing journey that this patient went through, and it still seems to be an ongoing thing. So that's why it's important to that we disseminate the facts of this particular procedure, but even hysterectomy. So that's another thing down the track, is once you remove the organs from the detach the ligaments from the structures of the pelvis, then the question is removing it, because I often see, yeah, maybe they don't use the uterine manipulator, but then they pull the removed uterus through the vagina. So the whole argument is like the vaginal access. So only if it's absolutely necessary, then it is medically appropriate. But if it's not necessary and it can be avoided, then it's not medically appropriate, and it's a crime. So that's why it seems this seems to be intersecting with a lot of authorities in our society, because often I see that surgeons aren't lawyers and lawyers aren't surgeons. That's why it's gone on for so long, and then no one's really alerted anyone. But now, because we have the internet, everyone's a bit more interconnected with information, and now we know what the truth is. And so determining like the if it's medical negligence or if it's the people who've done unnecessary genital penetration. Are they then criminals? We have to put it in a category because we just can't let this continue. It's like the patient actually ended up in a psychiatric unit with post-traumatic stress disorder because of the previous two surgeons that they saw about this procedure, that they were trying to scare him into giving consent into what is an unnecessary instrument. But so third surgeon, did it without it, and so and it was a successful procedure. It was very easy, actually. Like the 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 issue was like, the management of the uterus, and I see the photos here. This uterus is very small. The patient hasn't had any children, so that already, like, that's enough indication to know that you probably will not need any, like, like, it would be very easy to, like, move this uterus around because, one, it's very small, and it barely takes up the room in the pelvis, so there's plenty of room. But then also is the the urine. So you don't want a full bladder when you're doing operation because that's a risk. And so I see that doctors will use a urinary catheter during the operation. But this is such a short procedure that it would be sufficient just to make sure that the bladder is empty before the patient goes under anesthesia, and then the bladder just doesn't fill up with that urine in such a short amount of time. So the catheter isn't even necessary for this. I think the procedure went for like under 2 hours. So no catheter is required. Only afterwards, if the patient cannot urinate, cannot empty their bladder, and they've tried, then the catheter would be necessary to help drain the bladder. But that is the last result. At all times, you want to make sure that there is, like, if you can avoid it, then it must be avoided. Otherwise, then it is improper. So that was the issue here, that it caused the patient a lot of distress. And yes, so it was minimally invasive surgery. There was no C-section. It was like done by an experienced laparoscopic surgeon. Very minimal scars. The patient was discharged on the same day of operation, and they were walking the next day and driving the car and going to the shops. They just weren't lifting heavy items. So this is the perfect example of what minimally invasive surgery is, and it did treat the condition. Is that their hormones went into the right ranges after that. To conclude, this was a perfect example of like a surgeon who's done her job correctly, operated on a patient, didn't use any sort of genital insertion, removed the patient's ovaries, and everything went fine. It was a very successful procedure. And I would expect this level of care for all laparoscopic surgeons. But unfortunately, this is not the reality. Is that even in like where I'm from, Sydney, Australia, like quite highly developed, is that there are surgeons out here that are not doing operations appropriately. They're doing illegal methods of operation. So now police are involved, prosecutors are involved. We have like our medical council, the healthcare commission. But it's on an international level. These laparoscopic, people needing oophorectomies, hysterectomies all around the world. So that's the important part. Like sharing this information with the rest of the world, and then making sure people are operated on correctly and appropriately. But this is just one case. In each case is maybe in other cases the uterus is going to be much heavier and more difficult to manage while within the pelvis. And so maybe like having like a forceps lifting up this might not be sufficient. So there are other ways I've seen. So other research is telling me like that there's still ways to avoid genital insertion. There's like intrauterine sutures that can hold up the uterus while the surgeon's operating from within the pelvis, and that's a way to manage the position of the uterus without having to invade the patient. Or I see other even more like technological advance, like just engineering, surgical engineering, is that some sort of like suction device to manage the position of the uterus while operating. And see, they've had like this one's for lungs, but I reckon one for a uterus would be very I think clever. So you can see that they've this is how they like moving away other structures of without so like to me, like there's so many other like options available that avoid the whole the genital way. And so I feel like yes, we need to treat patients appropriately. So, and there's a lot of misinformation out there because I still do research, and here's like one video from freaking like Canada, Toronto. This is another like advanced city, and this video is literally the same procedure. They put something in the genitals. This is wrong. This is absolutely incorrect. We will be chasing them up about it. And they don't even tell you. They sneak you up on it. And then another thing I've heard, like the first two surgeons would be saying like, oh, you'll be asleep when it happens. No, this is not okay. Even if the patient is asleep, it is not okay. Obviously, like this is just such a big deal right now, and it's letting other people know, and that some people might be in trouble. This is yeah, well, it is rape, in a clinical setting, in a hospital. It's outrageous. So that takes me to my next work in progress, is that I titled it Appropriate Methods of Uterine Management in Laparoscopic Pelvic Surgery. I'm looking for co-authors for this. If you happen to be a surgeon or a researcher in pelvic surgeries, please email me. So maybe, yeah, if you want to work together, but this is what I'm working on. And I'll just conclude my presentation here. If there's any questions, I'll take questions.
Thank you, Dr. Anton, for your presentation. Any question?
I'll stop sharing my screen.
Okay, thank you.
Thank you.
I would like to invite
slides.
Good morning. Yes.
Yeah. Okay. Thank you. So, Assalamualaikum warahmatullahi wabarakatuh. I'm Tria from Indonesia. Currently, I'm working at Research and Innovation Danone Aqua, Indonesia. Today, I would like to share my latest publication regarding adequate drinking water and the correlation with the birth weight in pregnant mothers. So, for the introduction, as we know, fetus in the womb surrounded by the amniotic fluids, and the studies have shown that hydration through oral and or intravenous routes can improve amniotic fluid index in pregnancy. Sufficient amniotic fluid has critical role for mothers and fetus, such as to reduce prematurity rate, to reduce abortion rates as well. So this is the key elements of the fetus development. The largest single component of the fetus in the water, consisting of around 94% of its total weight, and all fluid needs are supplied by mothers. A fetus swallows between 200 until 450 milli per day of amniotic fluid at turn. And the 8th and the 9th week of pregnancy, the fetus already start to produce urine. So this is the daily intake recommendation. How much water should be consumed by pregnant mothers and breastfeeding mothers. In Indonesia, according to Minister of Health, the recommendation for adult women, at least 7 glasses or 1.8 liter per day. And for the pregnant, we need to add 1 glasses, so minimal 8 glasses per day or 2.1 liter per day. And also for the breastfeeding mothers, need to add at least 3 glasses per day, so the total is 10 glasses or 2.5 liters per day. Okay, the next one, the question, did Indonesian pregnant or lactating women drink enough? So the situation in Indonesia, looking at the publication from 2016, we found 42 or 2 out of 5 pregnant women did not meet the adequate intake of water. And 45% of lactating women did not meet the adequate intake of water. This condition will increase risk of the dehydration. So the impact dehydration during pregnancy, we can see from the mother aspect and also the fetus aspect. The symptoms for the mothers like dry, sticky mouth, sleepiness, feeling thirsty, headache, constipation, etc. And for the fetus, could be low amniotic fluid, premature labor, and also low birth weight. So we can zooming in into the low birth weight impact. The question is, does additional water intake impact to the amniotic fluid index? This is the publication in 2022, a systematic review. As I mentioned before, pregnant women requires extra fluid as there are physiological changes and fetal growth to maintain. Physiologically, there is intra and extracellular fluid retention in pregnant women to ensure good metabolism during pregnancy. So there is a condition, we call it oligohydramnions. Oligohydramnions is a clinical condition when the amniotic fluid volume is less than 500 milliliter or amniotic fluid index less than 5 centimeter of gestational age or a single deepest pocket. Studies have demonstrated adequate hydration intervention in pregnant women may improve oligohydramnions either by oral or intravenous hydration. Evidence has shown that adequate hydration therapy in pregnant women could improve condition in oligohydramnions. A review based on 4 studies in 2009 regarding the correlation between water intake and oligohydramnions have supported this hypothesis. The additional amount of water intake per day required by pregnant women with oligohydramnions to increase amniotic fluid index to normal range from 1,500 to 2,500 milliliters, depending on the condition of each pregnant woman. Additional water intake via oral can be a strategy for oligohydramnions therapy in pregnant women. So this is the systematic review about water intake and the birth outcome. Is there any correlations? This systematic review published in July in 2023. So the objective of this systematic review aimed to investigate whether the effect of water intake during pregnancy on infant birth weight followed by PRISMA principles. The study steps included eligibility requirements, information sources, study selection, metadata collection, and data item selection, which are the first 5 factors. We only examine factors which relevant to hydration. You can see in the slides that we focus on the hydration status and other relevant to hydration. So we are the authors ensure the predetermined inclusion criteria were met by data sources. The initial inclusion criteria consisted of studies that were original peer review and published in English during the previous 15 years, from 2007 until 2022. The second step of inclusion criteria involved pregnant women without any comorbidities, and the studies were either clinical trials or prospective cohorts. 6 papers were accepted for journal analysis because they met the prerequisites. Each of these 6 studies is briefly discussed, highlighting their respective strengths, weaknesses, methodology, sample size, intervention, and outcomes. The main focus of these studies was to explore the relationship between maternal hydration and delivery outcomes. Notably, all 6 studies found a positive association between better hydration or increased water intake and higher birth weight. The assessment of water consumption or hydration status in the studies was conducted between 8 until 37 weeks of pregnancy. 3 studies determined hydration status using urine biomarkers, while 5 studies collected data on the water consumption. Importantly, all subjects in these studies had no pathological condition. The consistent evidence provided by these studies indicates that low water intake or underhydration during pregnancy is associated with lower birth weight, irrespective of the duration of this study. This is 6 papers that we review. 2 studies utilize an RCT, randomized controlled trial study design, and the first study compared a standard care group with a daily water intake group of pregnant women. The intervention group also received education on nutrition and physical activity. This study revealed that the longer duration of underhydration, the lower the birth weight of infants. The second RCT instructs individuals in the third trimester of pregnancy to drink 2 liters of water within 2 hours and additional 2 liters per day for 7 days. The intervention group had a higher rate of normal vaginal deliveries, about 71% compared to the control group. The design of prospective cohort study was utilized in the other 4 studies. All 4 studies examined different aspects of nutrient intake and its relationship to pregnancy outcomes. The studies show that infant birth and weight and length are negatively impacted when hypohydration is present. Another study found a positive correlation between hydration status and pregnancy outcome based on the difference in birth weight between the 2 groups with a weight difference at birth. So in conclusion, this review has demonstrated a significant association between specific measure of water intake and the risk of adverse pregnancy outcomes, particularly birth weight. The optimal range of water intake associated with the increased birth weight was found to be between 2,180 until 3,000 milliliters. The review has also established a positive correlation between fluid intake and birth weight. Thus, pregnant mothers should not only focus on the nutrient intake and weight gain, but also pay attention to their fluid intake to support their health and promote fetal growth. For future research, it is recommended to conduct longitudinal studies with larger sample size and consider additional factors like energy intake and other potential risk factors in the analysis. Replicating the findings on the relationship between hydration status and birth outcomes is crucial as it may have important implications for maternal hydration status in the long term. By gathering more comprehensive data and considering a broader range of factors, we can gain deeper insight into the impact of hydration on pregnancy outcomes, ultimately contributing to better maternal and fetal health. So we acknowledge this review can be improved. So the weaknesses of this review are limited on the studies, the numbers of the studies, small sample sizes, various method in water intake data collection, various lengths of the intervention. Well, this review also have a strength. The study design, we have RCT and cohort study, and also we see the standardized on the low birth weight measurement. And this review, the systematic review, also using the recent publication. So the take-home message is most pregnant women in Indonesia are not sufficiently well hydrated. Water recommendation among pregnant women and breastfeeding women need to be increasing regarding the physiological changes and the effective way we advocate healthy hydration behavior through the establishment of hydrogenic environment. So remember, water is essential for mother and the fetus from the conception through the early years of his or her life. This implies that important health authority in each country to promote adequate water intake for pregnant women as well as the breastfeeding mothers. So this is the authors. We have 6 authors, myself and other experts from Indonesia, from Jakarta, Bogor, and also from Magelang. Thank you. Please email me if you need further information. Thank you.
Thank you, Dr. Jaya, for this informative presentation.
We are 6, Saifuddin, and the second authors, Yasir Haskas, the third author, Siti Nurbaya, the fourth author, Hasnita, the fifth author, Suhartatik, and me, the last is Abriati Mutmainnah. Our title of our research is The Effect of Diabetic Food Exercise on the Effectiveness of Blood Sugar Levels in Type 2 Diabetes mellitus patients at the Tamalanrea Jaya Health Center, Makassar City. Diabetes mellitus, or DM, which we call diabetes, is a series of symptoms, both absolute and relative, caused by an increase in blood sugar or glucose levels due to insulin deficiency. DM is a chronic degenerative disease whose number continues to increase from year to year. If this is allowed to continue without therapy, can cause complications. To prevent this, one of the pillars of diabetes management is physical exercise, namely diabetic food exercise. The purpose of the study was to determine the effect of diabetic food exercises on the effectiveness of blood sugar levels of type 2 diabetes mellitus patients in the work area of the Tamalanrea Jaya Health Center, Makassar City. This is South Sulawesi Province in Indonesia. The research design used is experimental with one group pre-test, post-test design. So we use one group, we use pre-test, and then just only group we also use post-test design. The sampling technique used was carried out with a total of 32 samples. The results of the study using the t-test pair samples test obtained a p-value is 0.000. It means less than alpha or significancy, and then the significancy is 0.05. The conclusion of the research results shows the influence of diabetic food exercises on the effectiveness of sugar levels in type 2 diabetes mellitus patients in the work area of the Tamalanrea Jaya Health Center, Makassar City. This is in accordance with research conducted by Nuraini and Arjita in 2019, showing that diabetic food exercises are very easy to do, can be indoors or outdoors, and do not require a long time, only about 15 to 13 minutes. and do not require complicated equipment like a chairs and a piece of old newspaper. At least foot gymnastics movements are done 3 times a week, but it would be better if they were done every day. Doing regular foot exercises can help a diabetes mellitus patient regulate his blood glucose levels within a normal and stable range. Thank you. Maybe Mrs. Mirna. I'm done with my presentation. Thank you.
Thank you, Dr. Amriyati, for an excellent presentation. Moving on, I'd like to call upon.
Fortunately, most of the time in the WHO reports, that there is always a high incidence of maternal morbidity and mortality.
Dr. Georgina,
so there is
please can you move
yes, please.
on your slides?
Okay, yes, please.
Okay. You need to run your presentation. Still with you only the first slide.
Oh, okay.
Yes,
sorry.
Yes. Okay, it's okay. Done.
Okay. All right.
Thank
Maybe
you.
I think it's a foot. Okay, you're welcome. Okay. So yeah, so I'm still on the background. So Ghana, like many other developing countries or nations where we are faced with lots of maternal health challenges, is actually most of the time these factors contributing to this maternal healthcare are multifactorial. There are a whole lot of factors playing into it, but this also includes a limited resources and then varying accessibility to advanced medical technologies. So against this backdrop, understanding the experience of midwives in utilizing obstetric ultrasonography is paramount for optimizing its integration into routine midwifery practices, especially at the primary healthcare level. So my study, or this study, actually seeks to conduct an in-depth analysis of midwives' experiences and obstetric ultrasonography in the primary healthcare facilities across the regions of Ghana. So by delving into the perceptions, their challenges, and then successes encountered by these midwives, the research aims to provide valuable insights that can inform policy, training programs, and overall improvement of maternal healthcare services in the country. So the objectives of the study. So we identified, or we came up with these 4 objectives. So the number 1 is to assess the importance or the value of obstetric ultrasound in midwifery care practices, to explore the impact of obstetric ultrasound on maternal and fetal health outcomes, then to examine the challenges faced by midwives at the primary health care in utilizing obstetric ultrasound. And then the 4th one is to identify potential solutions to enhance its integration into midwifery care at the primary health care level. So the methodology, so because it's a global conference, here, in order to, at least for those who may not know where Ghana is. So this is a world atlas, and that is indicating or showing Africa, the map of Africa, and then where Ghana is located. So actually Ghana is a small country. Okay. And then, so this is a Ghana map, actually the Ghana map here showing the various regions of Ghana. And then at the extreme right too is a community. So this mostly, this is some of the structures of a community health program service facility. So normally these ones are classified as a basic unit in terms of the primary health care. So these structures normally are being supported by the government and NGOs. Okay, so with a research design, we use mixed method approach incorporating both quantitative and qualitative design. So in a whole 361 midwives working at the primary healthcare facilities across the regions of Ghana participated in this study. So a convenient and snowballing sampling technique was used. This was used or regarded or considered appropriate because one, these participants are students, like I explained earlier on, who are working at the various facilities that across the regions. And so to actually get in touch with them, or to for us to get them in taking part, we decided to let them have the voluntary, that is, decide whether they want to take part. And then with the snowballing is to also help us so that those who we are able to reach, if they can help us also reach others within their facilities or other facilities who may be interested and willingly to take part in the study. Okay, so so just a brief description of the 3 levels of the primary healthcare. That is a description of the primary healthcare that we have in Ghana. So starting from the district health care level, so like I explained that already, that they actually they are the highest level of the primary healthcare facilities in Ghana, and most of the time they are well equipped in terms of being able to have a theater and a laboratory or ultrasound machine for the purpose of taking scans, the pregnant women and other conditions as well. Then we have the sub-district healthcare, which here basically we call it health centers. So the health centers, they are actually a sub-district or a sub-unit of the district level. So actually they also sort of augment the services of the district levels at the district levels, and but unfortunately for the sub-district healthcare, so the hospital or the facility is not well equipped. So normally in cases of any advanced treatment or any emergencies, they have to refer to the nearest district hospitals. And then we have lastly, the basic unit of the primary healthcare is the community-based health planning and services. So we call it CHIPS in short. So CHIPS, so mostly they are the basic ones within the communities, that is the very remote and then the rural communities, where they serve around 3,000 to 45,000 that is population. So that is where most of the midwives are also, that is where they are. And basically they are the head, like they sometimes a midwife will tell you that I'm the only person there, maybe with only maybe an assistant who is unskilled to help her in managing the facility. So basically, even if there will be any doctor or any physician assistant, that would be like the person visiting the area once a week. So the midwife basically takes care of the pregnant woman, has to make decisions with regards to their care. So okay. So the quantitative data were obtained through a structured survey questionnaire distributed using Google Form among participants. Like as I've already explained, is difficult because they are distributed across the countries. We thought this was a most convenient way to reach out to them to help us with the questionnaire. So the questionnaire actually has to do with gathered data that includes their demographic information, including years of experience, the importance of obstetric ultrasonography, that is ultrasound in midwifery care practices, and then the impact of obstetric ultrasound utilization on maternal and fetal health outcomes, and then the challenges faced by midwives. These midwives are the primary healthcare facilities as far as obstetric ultrasound is concerned. With the qualitative data, we generated through 6 focused groups. So with a total number of 46 midwives, and then each focus group discussion actually lasted between 45 and 60 minutes, and they were digitally recorded with the consent of participants. The analysis techniques for the quantitative data was descriptive statistical analysis and inferential test. So the data were actually organized using SPSS version 25. Then qualitative analysis was done by thematic analysis. Then ethical consideration. So electronically signed and verbal informed consent was obtained from all participants, and all participation was voluntary. So ethical approval was obtained from one of our highest institutions, which is a government one, and that is where the Garden City is affiliated with. Then with credibility, the issue of credibility and reliability. So all 3 researchers were involved in the analysis of data. And then later on, we also had an independent person reviewing our results. Okay, so results with regards to the participants' profile in terms of age, so between 26 to 35 years old were the highest. So they're recording 59.8% and representing a total of 216. And then with the lowest being between the ages of 36 to 45 years, representing 33.8% of a total of 122 midwives. In terms of gender, majority were females, so accounting for 98.1% and with a total of 357, and then male midwives representing 1.9% with a total of 7. Then with working experience, we had those who have worked less than a year, that is less than 1 year, and they accounted for 3.4% with a total of 14 midwives. And then 1 to 5 years of working experience accounted for 45.4%, making a total of 164 midwives. And then between 6 and 10 years working experience, we had 40.2%, accounting for a total of 145%. So at the levels of the primary health care, we had those working at the district, that is the first level of primary health care, accounted for 98.1%, which is, sorry, I think that there's a mistake here. The 90 is not 90, it's rather 4.1, because they formed the least participants. And then the sub-district, which is the health centers, which is the second level of primary health care, they accounted for 61.2% and a total of 221 midwives working there. And then the basic unit, which is the third level, or the CHIPS compound. Normally, we call them the CHIP compounds or the CHIP zones. So they are accounted for 37.1% and a total of 135 midwives working at those facilities. So with their results regarding the importance of obstetric ultrasound in midwifery care. So sorry, I think my information is a bit, I don't know, they are small, a bit small, but then, so the main importance of using obstetric ultrasonography as a diagnostic tool during pregnancy and childbirth. So with that, we have variables that include early detection of fetal abnormalities, facilitation of appropriate management decisions, improved assessment of fetal well-being, that is the fetal lie and any abnormalities, then enhanced patient education and engagement, then to determine sex of fetus. So this is one of the sections that we asked the midwives with regard to the importance of obstetric ultrasound in midwifery care practices. And so with all that, almost all of them were being answered or were being taken as important. Then with the aspect of obstetric ultrasonography that is most useful for your midwifery practice. So we asked them which aspect of the ultrasonography is most useful for midwifery practice. So in terms of variables such as assessment of placental position and function, evaluation of amniotic fluid levels, confirmation of fetal position and presentation, detection of multiple pregnancies, identification of potential anomalies or abnormalities. So with regards to that too, because what we did was we allowed them to take as many as they think is important in their practice. So almost all of the variables had a higher frequencies being recorded. Then with regards to aspects of pregnancy and childbirth, do you think obstetric ultrasonography benefits the most? So with variables in terms of early pregnancy confirmation, identifying multiple pregnancies, checking fetal position before childbirth, diagnosing fetal abnormalities, assessing fetal growth and development, monitoring placental function. So with all of them were being taken as very important with regards to the aspect of pregnancy and childbirth. They think ultrasonography will benefit most. Then we came to the challenges faced by midwives at the primary healthcare facilities in utilizing obstetric ultrasound. So with the challenges, we recorded unavailability or non-functioning of ultrasound device. Then we had cultural influence. Then lack of skills and confidence in utilizing ultrasound. Then over-reliance on technological information over clinical judgment. Then inadequate skills training. Then lack of technical personnel to service device when faulty. So these were the challenges that the midwives identified as being challenges that they faced at their various primary healthcare facilities. Then with regards to results with qualitative analysis, that is with the qualitative data, an overall theme that emerged during the analysis, which has been termed, has been termed obstetric ultrasound as benchmarking. So here it reflects the invaluable meaning the participants place on ultrasound in their practice. So before that, you remember I made mention of the fact that for some, they are the sole skilled birth attendants at the facility. And sometimes when it gets to the point of them making decision, because they are there alone or they are there with other non-skilled birth attendants, it becomes difficult for them to take decision. But with the help of ultrasound, with the help of the ultrasound, it helps them or it guides them in terms of their decision, or it gives them an opinion, or that is a confirmation to whatever they are thinking or whatever judgment that they are making. So with the sub-themes, another that is obstetric as a benchmark is guiding decision-making, then provision of tailored care, then avoiding complications, and then avoiding delays. So like I explained for the first one, so with those midwives at the primary or the remote areas, having the obstetric ultrasound available actually serve as a confirmation with regards to any decision that they want to make, or that is to whatever judgment or assessment they have already made. And then provision of tailored care actually talks about that is they being able to give a specific advice and then counseling or education to the woman and her family, and then avoiding complications. So because their facilities are not well staffed or with equipment and other technological devices, so it helps them so that they wouldn't wait or detain the woman until complications set in. So to them, it helps them to avoid any complications, and then avoiding delays. So we have the 3 forms of delays. So they talked about the fact that all these forms of delays are being prevented or avoided once they are able to confirm their decision or they are able to confirm their assessment. Then with regards to impact of obstetric ultrasound on maternal and fetal health outcomes. So here we have a section on maternal health outcomes. So the question was the use of obstetric ultrasound impact a mother's overall pregnancy experience. So that is midwife 4. We use because of anonymity sake. So midwife 4 says that the use of obstetric ultrasound generally enhances a mother's pregnancy experience by providing visible and clear insights into the well-being of the fetus, fostering a stronger emotional connection. And then midwife 9 also says that it's sometimes, referring to obstetric ultrasound, it sometimes heightens anxiety due to concerns about potential complications, but it also offers comforting. It also offers comforting. That is, comforting when everything appears normal. Then with regards to question number 2, he said, do you think ultrasound contributes to increased or decreased anxiety levels among pregnant women? Then midwife participant 14 or midwife 14 says that, I believe it, which is the ultrasound, can contribute to both increase and decrease anxiety levels. For some, it provides reassurance and a sense of control, while for others, it may introduce concerns about potential complications. So the maternal outcome still continues. So how well prepared do you think mothers are for the information provided during ultrasound sessions? Then midwife 42 says that majority of the mothers are illiterate concerning the benefits of ultrasound. Some have to involve their husbands, while others might benefit from additional education to better understand the significance of ultrasound findings. Then with regards to on section of fetal health outcomes, the question says that from your views, has ultrasound assisted in the early detection of fetal health issues? Then midwife number 20 says that yes, ultrasound helps in early detection. It enables timely intervention and improved management of fetal health issues. For instance, in cases of breech presentation. Then she further went on to say that Sometimes it depends on the time the woman reports to the clinic. Then another question on fetal health outcomes. How do you handle cases where ultrasound reveals potential abnormalities in the fetus? So, sorry, I think that this one shouldn't be there. Okay. So here, the midwife 22 says that you have to involve the family first. Then you provide emotional support to the parents, explain the implications of the findings. Even with that, sometimes it's difficult to convince them if you refer them for advanced care. Handling such cases is difficult. It takes the influence of opinion leaders in the community to convince them. Then the last question under the fetal health outcome says that, in your experience, have there been cases where ultrasound results led to changes in prenatal care plan? Then midwife number 6 says that, yes, in certain cases, ultrasound findings have prompted adjustments to the prenatal care plan to address specific fetal health needs and early referral to. So based on that, there's also a section on potential solutions to enhance obstetric ultrasound integration into midwifery care at a primary healthcare level. So with potential solutions that were suggested by the participants, state regular training for midwives, provision of advanced technological devices such as machine to detect glycol volume, and then provision of portable ultrasound machine, community education, and then engagement or involvement. So I move on to the discussion. So the in-depth analysis of midwives' experiences in utilizing obstetric ultrasonography in the primary healthcare facilities in Ghana reveals several key findings. So firstly, it is evident that midwives play a crucial role in the successful integration of obstetric ultrasonography into maternal care, showcasing varying levels of proficiency and confidence in performing ultrasound scans. So with this, it is similar, with this finding, it is found to be similar to a study by Devi and Hanifa et al. 2022, and then Vinayak and Andel et al. 2027 from Indonesia, a study from Indonesia and rural India respectively, accounting the invaluable role of midwives in using ultrasound. The positive impact of obstetric ultrasonography on antenatal care practices is acknowledged, with midwives emphasizing its contribution to early detection of complications and improved maternal and fetal health outcomes. So this is also supported by Humond, Taganira, and Advancing et al. 2017. Additionally, a study in Ghana by Abdul Mumin, Rotex, and Gumanga et al. 2022 identified the benefits of early identification of congenital anomaly if midwives are trained to, in the area of ultrasound utilization. However, challenges persist, including inadequate training programs, resource constraints. Midwives express the need for comprehensive and ongoing training to enhance their skills and address emerging issues. The accessibility and availability of ultrasound equipment also emerge as significant factors influencing the consistent utilization of obstetric ultrasonography in primary healthcare facilities. Then there was also cultural issues. So with a discussion regarding cultural factors such as patient consent and communication of scan results, further underscore the complexity of integrating this technology into midwifery care. So this is similar, this was found to be similar with a study by Ott and Campbell, 2018, in their study that investigates how cultural factors influence communication during prenatal care. Additionally, the study highlights the importance of a holistic approach that considers not only the technical aspects of obstetric or ultrasonography, but also the cultural context in which it is applied. So a conclusion and recommendation. So we recommended improved ultrasonography training programs among midwives in order to enhance midwives' confidence in this area. There is a need to develop and implement targeted training programs for midwives focused on obstetric ultrasonography, addressing both technical skills and cultural competency. There should also be continuous professional development opportunities should be provided to keep midwives abreast of evolving practices. Then resource allocation to primary healthcare facilities. Allocating resources to the primary healthcare facilities is important to ensure adequate and consistent availability of advanced technological use. Then 4 says that periodic maintenance and updates to technology to enhance the overall efficiency of obstetric ultrasonography. Then interdisciplinary collaboration. So in order to foster collaboration between midwives and other healthcare professionals, such as sonographers and obstetricians, to create a supportive network for knowledge exchange, consultation, and problem solving. Then community involvement. So community engagement strategies to educate pregnant women and their families about the benefits and significance of obstetric ultrasonography, address cultural concerns, and encourage active participation in the care process. And policy development. So policies that address ethical considerations surrounding consent ultrasonography, emphasizing patient autonomy, informed consent, and clear communication of scan results must align with existing cultural norms and practices. So recommendation based on future studies will consider pregnant women and intrapartum women on their experiences of routine ultrasound scan by their midwives. So this is that is what we hope to consider in the future. So this is our references, and on that note, we say a big thank you for your audience, and a big thank you for the organizers once again. Thank you.
Thank you, Dr. Georgina, for your presentation. Any question to Dr. Georgina? Okay, thank you. Ladies and gentlemen, it's time for us having a break. I would like to inform you that our break is until 15:20 p.m. It will be a great pleasure to have you.
So autism spectrum disorder is a neurodevelopmental disorder that is characterized by persistent difficulties in social communication and social interaction, as well as restricted repetitive patterns of behavior, interest, or activities. ASD affects daily functioning and participation, leading to significant challenges for both the child and their family. And caring for the autistic child is fraught with serious challenges influencing not only the child, but also his family. Family accommodation is a collection of responses or adjustments of the family to the demands of daily life of a child with a disability. It aims to minimize or alleviate the stress associated with the disorder and to sustain the family's daily routine. And it is highly prevalent among families of children with ASD. FA may include modifying family routines, actively participating in the disorder symptoms, or avoiding situations that may trigger symptoms that are associated with autism. For example, if parents know that their child is prone to temper tantrum in noisy places, they may choose to avoid going with him to the mall or to big family gatherings. Although parents use family accommodation to support their child's participation and reduce stress in the short term, it may lead to the worsening of the symptoms over time. Therefore, we would like to interfere and to try to decrease them. So let's talk a bit about the cannabis treatment. The cannabis plant has been used since ancient times. In 1937, it was prohibited in the United States as it was classified as a dangerous drug. In 1963, research distinguished between two main phytocannabinoids, the CBD and the THC. The CBD is an anti-inflammatory, antipsychotic, and anti-anxiety chemical, and the THC is mainly responsible for the high sensations that people feel when they use cannabis. So by isolating these two cannabinoids, it was possible to use various dosages in order to make medical cannabis that can be tailored to treat specific medical needs. In 2014, cannabis was approved by the FDA for the treatment of specific types of refractory epilepsy in children. And in 2019, we saw first researchers about the safety and effectiveness of cannabis treatment among children with autism. Only to date, most of all the studies concentrate about and focus on the way it helps and assists children, and little is known about how it helps families. Our mixed method study aimed to examine the effect of medical cannabis on parental well-being and on family accommodation. And we looked also into parents' perspectives regarding the benefits and barriers of this treatment for both the child and family. We analyzed data from 44 children ages 5 to 15 years old during 3 different times. Time 1 was before cannabis treatment, time 2 after 3 months of treatment, time 3 after 6 months of treatment, and following the completion of the treatment, 15 parents of children from the full sample participated in in-depth interviews. We use the following measures: the ADOS, Autism Diagnostic Observation Schedule, second edition, to confirm the ASD diagnosis. We use demographic questionnaire, and we use the family scale for restricted and repetitive behavior, FAS-RRB, which aims to assess the frequency of accommodating behaviors experienced by families of autistic children due to repetitive and restricted behavior and interests. The scale includes 11 items. The first 7 items relate to the frequency of accommodating behaviors. The 8th item addresses parental distress caused by accommodating behavior. The last 3 items relate to the child's short-term response if no parent accommodation is made. So let's take a look about the results. So first, the quantitative results. Following 3 months of cannabis treatment, we saw a decrease in the frequency of accommodating behaviors. We can see that from time 1, that is before the intervention, to time 2, that is 3 months after of intervention, a significant decrease in the frequency of accommodating behaviors, and this kept decreasing a little bit from time 2 to time 3. We also saw a decrease in the negative child short-term response, and we could see that it was significantly decreased from time 1 to time 2, and then it went into a plateau and stopped decreasing, but didn't increase from time 2 to time 3. Thirdly, we saw a significant decrease in the parental distress following the cannabis intervention. Here we see something really interesting, a beautiful decrease in the parental distress from time 1 to time 2. In the first 3 months of intervention, then it started increasing, either the parents kind of like got used to it, and or something else that we don't know, but parental distress started to increase a lot. As we didn't have time 4, we don't know what happened after a year, for example, so we don't know if the parental distress went back to the beginning point or plateaued. Regarding the qualitative results, so we saw both the treatment benefits, maybe benefits of the treatment, but also some barriers, which we'll talk about later. So the benefits included the benefits both for the relating to the child symptoms and the parental or family factors. The child, we saw an increase in participation and in communication abilities, and a decrease of maladaptive behaviors, which is exactly what we wanted to see, or what the parent wanted to see. And regarding the family factors, we saw an increase in the sense of well-being of the parents, their ability to integrate and participate in big family events and social environment events, and their ability to better participate in job and leisure events. Here are some results from the first sense of well-being following the cannabis intervention. You can be more relaxed, you can enjoy your food. Once these behaviors decrease, it allows me as a human being to enjoy the situation a little bit more and not be so alert. You don't sleep at night for 3 months, and you have to be constantly awake and be with him. And then we started, it was a huge improvement. Cannabis decreased his anxieties, so now he can eat next to us, which is a huge improvement for us. We don't have to run away from home anymore. So regarding the positive implications for occupation of the parents and leisure time of the parents, I couldn't wake up to work. I was just tired. Today, I work in the mornings, and in the evenings, they can actually go to events. Members that he didn't want to visit. Cannabis gave him more support, and he felt more confident. So as I said before, we saw a lot of advantages, but we also saw some treatment barriers. Basically 25% of the parents also reported barriers. And these include intake difficulties, side effects, and maintaining the treatment in the community. So the intake difficulties related to the oil, and autism are prone to sensory symptoms such as overreactivity in all senses. So we can just imagine that a child that is sensitive to taste needs to deal with a new taste, and specifically with the bitter taste. And the second intake difficulty was a very strict protocol that the parents had to deal with in time and regarding dosage. That was pretty hard for the parents. They also reported the side effects, such as, and indeed, parents whose children experience this kind of side effect still in the community. They received the cannabis oil within the study, and the doses was adapted specifically into the child's needs. And once they completed participation in the study, they had to go to the community to find a doctor that will support cannabis treatment and will find the right dosage and the right drug for them. So that was also it was very costly. Before, it didn't cost them any money to participate for 6 months in the study. So it was pretty challenging. Here are some quotes for them. "I thought the cannabis would actually help him, but it was going entirely somewhere else. He became nervous, very aggressive. He wasn't ready to taste it. It did not work. He almost vomited every morning when he took it. Not to forget, be careful, as the dosage is very, very important. Find the exact amount that does good for the child, the exact hours, constantly being on it, constantly paying attention to changes." Also, as I said before, they had challenges maintaining the treatment in the community. "The type of cannabis I received at the pharmacy is not suitable for my son, and now he is in regression. It is hard to find the right time and dose." We're still searching for a doctor who will follow up this to expire, and Dr. X can't renew it for us. It's very expensive. It cost 550 shekels, $150 for us. This is very expensive. I think it should be cheaper and more available for these children. So let's conclude. Results support the effectiveness of medical cannabis treatment in reducing FA and subsequently reducing parental feelings of distress and enhancing parental well-being. However, this treatment wasn't free of barriers. Results highlight the burden imposed on parents and their need for welfare and professional support to ensure access to appropriate services. Thank you for listening, and I would like to thank my colleagues, Dr. Orit Stolar, who ran this study, and Ayelet David, who is a PhD in this study, and of course my department, the Occupational Therapy Department at the University of Haifa in Israel. Thank you very much.
Thank you, Dr. Ainat, for your presentation. Any question to Dr. Ainat?
Hypertensive disorder of pregnancy are classified as persistent hypertension, preeclampsia, preeclampsia superposed to pre-existing hypertension, and gestational hypertension. Globally, 10% of all pregnancy. Specifically, preeclampsia, which complicate 2 to 5% of pregnancy worldwide, is unpredictable and progressive. Between 45,000 to 46,000 maternal deaths and 500,000 fetal and newborn deaths are linked to preeclampsia annually. So we are talking about a very serious, complicated disease that could happen maybe between 2 and 5 pregnancies worldwide. Okay? So persistence that persists the high blood pressure until at least 12 weeks postpartum. Now, with this situation, we say, what is our problem to go ahead with this research? The lack of indices based on risk factors that accurately predict the possibility of developing postpartum persistent hypertension with patients with history of preeclampsia. We are focusing in what is going to happen with a pregnant mother or a postpartum mother in the first 48-hour postpartum, for example, who develop preeclampsia ahead in the next 12 weeks postpartum, could remain as a chronic hypertensive patient, will solve totally the systemic endothelitis. So that is the reason our general objective was to design and validate 2 indices based on risk factors that predict the development of persistent postpartum hypertension in patients with a history of preeclampsia. We conduct a study for 3 years in 3 maternities in Cuba: Carlos Manuel de Céspedes Teaching Hospital, Juan Bruno Sayas Teaching Hospital, and Agustino Neto Teaching Hospital. We did this study for 3 years. We include all preeclamptic patients, but specifically have to be a pure preeclamptic patients. Cannot be preeclampsia with another condition, just preeclampsia. We exclude the patient with chronic hypertensive or pre-existing hypertension before pregnant, a patient with any renal disease or any renal condition, patient with collagenosis like lupus or others, and patient with pre-gestational diabetes. In our study, those patients that we cannot meet 12 weeks postpartum were removed from the study. So our dependent variable was postpartum persistent hypertension, and we assess at least 26 factors. We use the Daniel formula for the calculation of the sample size, and we achieved 215 patients that has to be studied. What we did is we divide 75% of the sample, were 162 patients, for building the 2 indices, the construction of the index, and we keep 25% of the sample, were 53 patients, for the validation of the 2 indices. So we follow for at least 12 weeks postpartum during 3 years, 215 preeclamptic patients. So statistically, we did a bivariate and multivariate analysis. Specifically in the multivariate analysis, we did a COTS proportional regressions. So we moved to the construction of the 2 indices, the validations, and always taking in consideration the ethical aspects. So after we did the bivariate analysis and we did a cost proportional regression, we found that at least 11 variables were very significant in our study, linking or associated to the persistence of postpartum hypertension 12 weeks postpartum. They were diagnosis of preeclampsia before 34 weeks, proteinuria more than 2 grams in 24 hours, bilious infarction, placenta dysfunction, pathological uterine artery Doppler at 24 weeks, creatinine beyond 0.8 milligram per deciliter, age more than 30 years, lymphocytic vasculitis, thrombosis, and decidual necrosis, history of mother or sister with preeclampsia, aspartoaminotransferase beyond 92 international unit, and the development of intrautero growth restriction. So, basis in those factors, we move to prepare two indices. One that use a histological result of the placenta that we call index with the placenta finding, and another one without the placenta finding. Why? Because we know 6% of the postpart of the preeclampsia could be made the diagnosis in the postpartum period. So in those cases, we don't have the placenta to go ahead with the study. But those patients cannot be orphaned for the condition that we didn't pick the placenta for histological study. That is the reason we prepared two hypertension. One that was using all the factors except the placenta finding. So it is a fast index we prepare with the punctuation, the weighing in 15 points that we use. Let me go back because it's important. We use the hazard ratio in the cost proportional regressions to ponderate, to give the punctuation to the index. And we use, for example, the connection is unstable again. I think you are listening to me. Do you get me well, please? Hello?
Yes, we can
Hello?
hear you.
Well, because it's not very stable, the connection. I'm very sorry for that. So we use the hazard ratio. So all those variables that the hazard ratio was beyond 1.5, we have given 2 points for the index. And those with the less than 1.5 in the hazard ratio in the cost proportional regression, we gave 1 point. That is the reason we achieve the fast index with placenta study for the predictions in 15 points using the variable we described before. You see only 4 variables were in 2 points. The rest were in only 1 point. So what was very interesting from here is that after we went for the validation of the index, we have 3 categories for the index. If you get between 0 and 2 points, we category you 1 and low risk. If you have between 3 and 6 points, we category you into moderate risk. If you get at least between 7 to 15, we make you in the category 3 and we put you in a high risk category. So when we did the ordinal index according to the risk categories, was very interesting to see that those patients who got low risk from 94 patients, only 2 got morbidity. Only 2 cases from the 94 that were classified in category 1 got postpartum hypertension. From 54 that were in category 2, only 53.7% of the patients got postpartum persistent hypertension. But what is here important and significant and highlighted is that 14 patients got the category 3 between 7 and 15 points. And when we follow those cases, the 100% of the sample, the 14 patients, they develop postpartum persistent hypertension. So we could say that this is very good. It's a very sensitive index that when it's classified you as a sick patient, most likely you will be a sick patient. So when we see the internal validation of the clinical pathologic index, the one who use placenta, what were very significant is that is 97.2 sensibility, low specificity. We have to say that the majority of the cardiovascular index are like this, with high sensibility and not too very high specificity. However, the positive predictive value and the negative predictive value, they were very, very well. So we conclude in this index that is very good to predict postpartum persistent hypertension. So the second index we building was the one without placenta, and this index was using for those cases that we cannot pick the placenta. Recommended for every maternal preeclamptic patient, please. If you have histology, do that, because it's a find that could tell us it's a hypertensive process in this patient. In this case, is for the cases that we didn't pick the placenta, we can show without a placenta findings. So for this, we that were in low risk 108 patients, and only 5 to the first index is when moderate and high risk, because you see patients in category 2 of moderate postpartum persistent hypertension, what is 72.7%. And from the 10 of the category 3, at least 8 develop postpartum persistent hypertension. What happened with this? We can say from the index with placenta is just significant only if you are in category 3. However, for the ordinal index, according only to clinical findings, you are at risk to get persistent hypertension. However, whatever you are in category 2, the 72% of the patient develop postpartum persistent hypertension. So in this index, what was more positive is that the sensibility of the index, it doesn't reach 90%, was 88. However, the specificity of the index was 88%. So has a balance between the sensibility and specificity. The positive predictive value and the negative predictive value were very well also. So that was very important. So we can show you in the building process the area under cube, that is important. The receiver operative in the seats for the index with placenta. When we study the 0.9, we can say that the red model is doing well. In the building process, we are specifically here, building validation process. They were very good, so they can predict very well the probability to get persistent postpartum hypertension after you suffer a preeclampsia. We want to get the eta. This is very significant statistic in the conclusion validity of the both index And we go in the one with placenta, 0.726. In the one without placenta, the eta was 0.732. Statistically, it's very well, because when it's more close than 1 to 1, we say that the index are working well and have correlations. So it was very important in the conclusion and the validation. So see here, in the validation of the index, how the index with placenta get a very good area under the curve, and the index without placenta is still as good, not very good, in 0.8, but were significant that both indices are very well in the prediction. So we achieved this conclusion. Number one, the diagnosis of preeclampsia before 34 weeks, the proteinuria greater than or equal to 2 grams in 24 hours, the bilious infarction and the placenta dilution were factors with the greatest influence on the appearance of persistent postpartum hypertension. The two indices created and validated from the risk factor allow us to predict with adequate reliability the appearance of persistent postpartum hypertension in patients with a history of preeclampsia. Now, what is our recommendation to the community, to the obstetric community, midwifery community is, in Google Play, for any telephone that is not iPhone, I'm very sorry, we are still in the negotiation with the iPhone telephone, the iPhone company, sorry, and we are expecting answer for maybe the next 6 weeks. But now for any telephone, any Android telephone that is not iPhone, is not phone, you can go to Play Store and you can put there HPP predictor. Will be a red heart there, so you can download the application, and the application has the two calculators. The calculator with the placenta findings and the calculator without placenta findings, and will be very practical for you, for any patient with preeclampsia that you have from now. As soon as you make a diagnosis of preeclampsia and the delivery, and you have the histological result from the placenta, you can use the calculator, and the calculator will give you the punctuation, the prognosis, the category, will give you everything. Will be so practical. So I am going to be so grateful is from now you can validate the use of this calculator to predict the persistent postpartum hypertension in patients with history of preeclampsia. Thank you so much.
Thank you, Professor Yarin, for this informative presentation. Any question?
Great, lovely. Okay, so I might do it from my own slide. Might work better. Okay. Just waiting for the slide to come up.
We have shared your presentation.
And I can't find it on yours, so I'm using mine. Just won't come up. Try again. Okay, I've got it now. Infection is a hazard of wet nursing. Sorry for the delay. Now, the background, my own research is on wet nursing in Australia. The European situations covered are a collaboration between Dr. Thomas Schroeder in Poland and myself. The topic is occupational hazards of wet nursing, but particularly the 19th century. That's the topic of the research. Definitions. Wet nurse, a woman who hired herself out to breastfeed the baby of someone else, for instance, as an occupation. Compare with dry nurse, a woman who fed another woman's child artificially. Accounts of risks of wet nursing usually focus on potential risk to the child of the employers and the moralistic pronouncements of medical men and churchmen on the biological mothers who employed them, rather than the fate of the wet nurse's own child, not a homogenous situation, or her lived experience. Of all the people involved in the wet nursing scenario, the one who seemingly mattered least as an entity was the wet nurse. Some fell into wet nursing after a stillbirth or infant death. Others were single women or deserted wives, for whom the milk supply that resulted from the pregnancy was often their only asset, their only way of earning enough to live. Others were married women with breasted milk and who weren't destitute. I might just mention here short-term wet nursing, informal wet nursing that also happened among friends or relations, perhaps to oblige a new mother with delayed lactogenesis or for other reasons such as illness. Wet nursing was known from ancient times, and it was known that if not maternally breastfed, wet nursing gave an infant the best chance of life, especially during epidemics and pandemics, when the purposes of prevention and treatment were primarily to protect the child being wet nursed. Well, why become a wet nurse? When the mother had a breast of milk after a stillbirth or infant death, it was often her only asset. Oops, somehow I've lost that slide. Here we are. In the 19th century Australian colonies, desertion or not being supported could happen when her partner left for seasonal work or to seek his fortune in the goldfields. That was before the time of telephone or any other kind of communication that didn't take some time. So she could be really left not even knowing what had happened to him. So recruitment. In 19th century Australia, wet nurses were typically found through family doctors, wet nurse wanted advertisements in newspapers advertisements by wet nurses seeking position, and benevolent institutions, which usually required a lactating inmate to breastfeed another child besides her own. If the woman gave birth in a benevolent institution for the destitute, she often stayed in for a few weeks and was often depended on the institution, but was often required to breastfeed another child besides her own. Examples of wet nurses. Wet nurse wanted to any person disposed to wean her own child. This is a good appointment. She would be required for about 6 months, receive liberal wages, and have a home with every comfort. Apply by letter to Dr. Rowland's Ipswich. That was one for a rather advantaged position in 1862. Another one, wet nurse, a respectable married woman, having lost her own baby, milk 14 days old, wants a baby at home to nurse. It's from 1872, one of many such ads. She emphasises that she's married, she emphasises that she's lost her own baby, and she emphasises the age of her milk, meaning how long since the birth, because some people preferred a wet nurse whose baby was a newborn, or at least close to the age of their own baby. In healthy women and nurslings, many advertisements emphasise the health of the prospective wet nurse. Medical doctors often had a hand in selection. So for the most part, any risk of infection was minimal. This paper, however, looks at the exceptions. Supposed transmission routes for infectious or contagious diseases were debated because knowledge evolved over time. For instance, particularly in relation to syphilis and yellow fever, sometimes, often wrongly, the milk was believed to be a vector for transmission, whereas transmission had been through skin contact or proximity, which might have included sharing spoons, for instance, sharing spoons with another servant with oral lesions or skin infections. Let's look at syphilis first. In 1494, the first epidemic in Europe spread like wildfire through a population that was naive to that infection. And then throughout Europe for 4 centuries, attempts to treat affected infants through the breast milk that they ingested, including dosing the wet nurse or the mother with mercury in the hope of treating the infant through her milk, and steam baths and bloodletting to make her milk therapeutic for the infant. Now, we know now that steam baths and bloodletting are not going to make her milk therapeutic so that she can treat the infant. But that was the belief from 1494, 1594, 1694, and through the centuries. Transmission of infection in both directions. Treatment of syphilis was common enough to be mentioned in Shakespeare, though readers of today might not realise what the treatment he mentioned was for. In 19th century England, syphilis is believed to have affected up to 10% of the male population. Although transmission from infant to wet nurse happened, especially in the case of congenital syphilis, and had been known for the previous couple of centuries, it was still debated in UK medical journals in the mid-19th century, so knowledge had actually regressed. Let's look at chains of infection for syphilis. Chains of infection for syphilis, the disease of most concern, through transmission, such as through wet nursing, also developed, for instance, in Boston, the United States, when the engorged breasts of several local women were sucked by a pap suck. Pap suck was an occupation, would you believe, where an adult who was usually female but could be male, sucked the breasts of new mothers with engorged breasts. The profession still existed in the 20th century, I believe. The child of a pap suck was suckled by other women in the community. And in the case of Boston, the child infected them. Other long chains of infection also stem from just one individual. In Stockholm, such a chain of infection was described by the early paediatrician, the Swede Nils Rosen von Rosenstein, in 1778 in his book, who also cited cases described by other authors. However, congenital syphilis was the most common route of transmission in babies born to syphilitic fathers. A common medical misconception was that an asymptomatic mother was free from infection, that the infection had somehow bypassed her. So hiring a healthy wet nurse was believed to protect the innocent mother. Of course it didn't, and the wet nurse was put at risk. When latent syphilis was mistaken for a cure, when it went into its latency stage, some of the children born to a man with apparently latent syphilis could have no visible signs of syphilis or delayed onset of rash, skin discoloration, or other symptoms in the infants, or other signs and symptoms, yes. Some of the man's offspring might have signs, others might not. So just the fact that the child had no visible signs didn't mean it was going to be safe. Thus, there could be no reason for a newly hired wet nurse to suspect the disease, especially if a respectable family wanted to hide its secret. Kurtzer reported a tragic case in Italy in 1890 of a foundling from a large foundling hospital given to a young village wet nurse to take home to rear. The child was symptomatic, but she was wrapped and her face was hidden during the long journey home on the train. This tragic case was not the only one. The syphilitic foundling innocently infected the wet nurse, and through her husband, child, and subsequent pregnancies. With no effective treatment, the family's fate spiraled downwards. The court in Italy awarded damages, but they were completely eaten up in the fees of the crusading lawyer who took the case. Now, let's just go back. Treating syphilis most commonly was by mercury, either internally or by external application rubbed on the skin. And for 4 centuries, it was the go-to treatment for syphilis. And there was great faith in it. In early modern Europe until the 19th century, physicians believed that mercury in high enough doses, whatever was high enough was a matter of belief, would sweat out syphilis from the patient. There was a question, of course, of whether the dose actually passed through milk to treat the child and what dose would have been adequate if this were possible. The side effects of mercury were as bad as the disease. In the 18th century, leading medical authors in Europe debated whether salivation as a severe side effect indicated that the mercury treatment was being effective. Mercury is highly toxic. Think of mercury exposure in Victorian era hat makers with erosion of the jaw from the mercury, and the 20th century community exposure in Minamata, Japan, which wasn't all that many decades ago. Now, I want to mention how late the identification was of the causative organism. It wasn't until 1905 that the causative organism was actually identified, which was the spirochete Treponema pallidum. In 1906, the Wassermann test for syphilis was developed, a breakthrough at last. Treatment with salvarsan, which is a mercury derivative, but less toxic than the mercury that was previously used, was used from 1909, despite difficulties processing it due to its instability. The advent of antibiotics in 1943 eventually provided an effective treatment. Let's look at other transmissible diseases: plague, smallpox, cholera, yellow fever. Communities had high mortality rates. Infants, however, who were not maternally breastfed were even more at risk. Plague spread from infants brought from cities with epidemics to be wet nursed in rural villages in England and Europe. As a result, plague could wipe out entire families of village wet nurses. Quarantine and isolation was used in Europe against plague from early modern times. There are many accounts. In Europe, municipal authorities in Hanover and Thorn sent wet nurses out to families during the plague epidemics in Hanover and on the Baltic. However, lack of isolation caused high mortality in foundling hospitals in Marseille in 1720, but not in Moscow, because in Moscow they practiced strict isolation. Foundling hospitals, by the way, were crowded with infants. Many women who gave birth to unwanted infants put them into foundling hospitals, and the numbers of such infants was amazing to today's readers. Lactating women in villages near London had long accepted wet nurses from London, as it was customary to send infants out of the crowded cities. However, during plague years, this practice proved to be a cause of transmission to villages. Sometimes it was carried in not only on the babies, but in the clothes they were wrapped in and in the bedding. For instance, at Much Haddam in England in 1603, 2 families engaged in wet nursing were wiped out by plague. And that's cited by Valerie Fields' book on wet nursing. During plague outbreaks, however, healthy infants were found sucking at the breasts of dead mothers, as they had been protected by the milk. And yet sick mothers were advised not to breastfeed. Medical authorities such as the Frenchman Ambroise Poiret in 1649 advised wet nurses to protect themselves by anointing their nipples with sorrel juice before feeds. There's no information on outcomes, and I think we can be skeptical about that. And that I've cited that in a paper that my colleague and I published a couple of years ago. And here's a well-known picture from Free Access of the plague epidemic and people dead in the streets. And you might see here a child trying to crawl to the mother, or a baby here trying to get to a mother who's clearly dead. Absolutely heartbreaking. So let's now look at smallpox, which we can now celebrate as a disease now eradicated. People of my vintage were vaccinated against smallpox and still have marks on our arms from the vaccination, but of course it's now eradicated. Back when it was rife, a high mortality occurred across the general community, including, of course, among mothers and wet nurses. Infants at breasts of ill women remained well during outbreaks. Yet the Swedish medical author Nils Rosen van Rosenstein blamed poor infant outcomes on too much meat, in the wet nurse's diet. So he wasn't recommending that they wean the infants. Yellow fever was another infectious disease, and in both North and South America in the 19th century, wet nurses in Brazil were blamed for the transmission to infants, as knowledge of the etiology of this disease had yet to evolve. It wasn't known at that stage that it was mosquitoes that were the vector. However, in Philadelphia, perhaps wiser city authorities wisely recruited wet nurses to save orphaned infants in their yellow fever epidemic. Cholera was rife in all sorts of countries. In fact, there was a book written, A History of London in the 1830s, and the title of it was King Cholera, because that was the big disease in London then. However, instead of sidetracking, in cases of cholera, infants under 6 months were apparently usually unaffected, even if the mother or wet nurse was herself ill. At the Child Jesus Hospital in Warsaw, a number of wet nurses were ill, but the infants they breastfed remained healthy. In cases of gonorrhea, gonorrhea was not considered an absolute contraindication to employing a wet nurse, and it didn't crop up as a contraindication in the many medical authors we researched for our paper. Pulmonary tuberculosis, or TB, and other forms of tuberculosis were common in the 19th century. They were very common, but TB was not mentioned by medical authors as a contraindication by women with the disease for breastfeeding. Several terms were used for pulmonary TB and other forms of TB, and they were used interchangeably in England for much of the 19th century. There was a great deal of confusion. So, and my references are Valerie Fields, The English Wet Nurse and Her Role in Infant Care, 1538 to 1800. David Kurtzer, Syphilis, Foundlings and Wet Nurses in 19th Century Italy. Koutsoukis, Mercenary Wet Nurses, and that was about Brazil in the second half of the 19th century. And Rosen von Rosenstein, the diseases of children. This was a huge pediatric text, published first in Swedish and then translated into French. I read the French translation first. I've subsequently got the English translation. It was considered practically the Bible of diseases in children, you know, and used by physicians in Sweden, in France, and in England. And other references are the papers by my colleague and myself, Unfortunate Creatures, The Hazards of Syphilis in Wet Nursing. It was published in English in a Polish journal. And another one, Infection, A Hazard of Wet Nursing, How Beliefs About Transmission Historically Have Shaped Protective Measures, which was published last year in the Journal of Human Lactation. I've also drawn on the World Health Organization's Guiding Principles for Feeding Infants and Young Children During Emergencies, and the Boston cases were cited by John Winthrop, who lived in the 17th century, but the History of New England edition that I cite was published much later in the 19th century. Okay, now, any questions?
Thank you, Dr. Virginia, for your representation. Any question?
Hello?
No question, Dr. Virginia. Thank you for your representation.
Thank you.
Thank you. Moving to the next speaker, Dr. Norgia Mashava from University of Pretoria, South Africa.
Introduction through limitations. Emergency obstetric care is one of the strategies used to reduce maternal and neonatal mortality. And this is done by employing specific interventions during pregnancy, delivery, and the postnatal period. The 3-delay model was developed in 1990 by Thaddeus and Men, and this was to understand factors that may contribute to maternal mortality. And when we talk of the first delay, it's about making this delay occurs in a home where the mother has to make, or the family has to make the decision to go to the hospital. And the second level of delay is associated with the barriers in reaching a health, but because of poor lack of transportation, poor roads, you finally delay in reaching the hospital. And the third delay is delay which occurs at the level of the hospital. Maybe it can be delay in receiving proper care, or maybe receiving or being referred to other facilities where you can be well managed. Delay in access to quality care has been identified as one of the important determinants of preventable maternal death. Like we said, the 3-delay model was developed as a way to understand the environment surrounding maternal mortality and has been used in countries across the world to reduce maternal mortality. Over 500,000 women die each year due to pregnancy complications, and the vast majority of which we can prevent. Cameroon, like many other sub-Saharan African countries, has a high burden of maternal mortality. The global decline by 44% that was experienced by many other countries was not the case with Cameroon. Instead, Cameroon had a rise in maternal deaths with 782 maternal deaths per 100,000 live births. That was in 2015. Previous rates were 669 in 2004, 554 in 1998 respectively. And we have realized that the Cameroon government is now focusing on interventions like family planning, infection control, increased training of healthcare professionals, and seeking emergency obstetric care. So the purpose of this study was to identify factors that to contribute to a reduction in maternal mortality. So the major objective of this study was to assess factors associated with delays in emergency obstetric care in order to contribute to reducing maternal mortality, and the specific objectives were to seek emergency obstetric care, to assess contributing factors related to access in emergency obstetric care. Please, can you hear me? Can you get me?
Yes, doctor.
Okay, thank you. The third specific objective was to evaluate the factors that hinder receipt of adequate emergency obstetric care at the level of the health facility. And this study, looking at the materials and method, it was a community-based cross-sectional study that was carried out for a period of 6 months. That was from March to September 2022. That was last year. And like I said, it was carried out in Tubah district. And the study sample was 420 women, and the sampling technique was multi-stage sampling. Can you hear me, please?
Yes. Yes, I can. Yes.
Sorry, I'm having a challenge with network, so you bear with me. So like I said, the sampling technique was a multi-stage sampling technique where out of the 7 villages that were in Tubah district, 4 of them were selected, and then purposefully households were selected where women of reproductive age were approached and structured questionnaires were administered. In criteria, women of reproductive age that were found in the community during the period of study and accepted to take part in the study were included, and for exclusion criteria, all women of reproductive age who had never been pregnant or were pregnant for the first time. So this was based on the assumption that women who were pregnant for their first time, they might not have experienced or have had any delay as far as emergency obstetric care was concerned. So that's the reason why they were excluded. And for data collection, it was self-administered structural questionnaire, and data was analyzed using SPSS version 21. For ethical consideration, authorization was gotten from Institutional Review Board of the University of Bamenda, authorization from the Regional Delegation of Public Health, and informed consent was gotten from the participants. So based on the socio-demographic characteristics of the participants, majority of the participants were between 20 and 29, that's 40%. And then for educational level, we realized that majority, that was 47.9%, had at least secondary level, had gone to secondary school. And for occupation, most of the participants were housewives. And this was closely followed by women who were self-employed. Based on religion, 336 women, 336 women were Christians, and just a few of them were Muslims. And based on those that had attended antenatal clinic during pregnancy, we found that 86%, 86.2 of those women had attended antenatal care. And based on their marital status, 60% of them were married, which was above half. And looking at the factors that influence decision to seek care, firstly, a bivariate analysis was carried out, and factors that were found to be significant at the bivariate analysis, they were taken to multivariate analysis to assess the risk of delaying in reaching care or in getting care. So for the first delay, which was about delay in making decision to seek care, we realized that those who were less than the age of 20, they were more at risk of delaying than those who were at least age 30 to 39. This was statistically significant. This was just based on the reason that most persons pregnant for their first time, they are not experienced any pregnancy, so they never knew the complications that could be involved or that were involved or that are involved in delaying to make a decision to go to the health facility. And based on their religion, we realized that Christians had a high risk of delaying in getting to the hospital, and this could be explained that majority of the participants were Christians. And based on their monthly household income, we realized that those those with the household income less than 25,000 francs, they were at risk excuse me, they were at risk of delaying in making a decision to go to the hospital than those who had income greater than 100,000 francs per month. We also realized that decision makers, those who made decisions for the women to go to the hospital, that in cases, women who made decisions on their own were more at risk of delaying to get to the hospital than those whose decisions was made by maybe the husbands, the neighbor, and family members. And looking at the knowledge, assessing their knowledge on danger signs, we realized that women who had no knowledge on danger signs during pregnancy were at risk of delaying in making a decision to go to the hospital, because you know when to leave home and to make a decision to seek care on time. And looking at those who had attended or who attended antenatal care, we realized that those who had not attended antenatal care had a higher risk of delay in making a decision to go to seek care, and this was statistically significant. So we realized that 53.8% respondents reported difficulty in making a decision to seek emergency obstetric care, and this was higher compared to other studies that was carried out in Bahida, that's in Ethiopia. And this was lower than 73.3% who reported first delay in Tanzania. And based on their age, we realized that with respect to maternal age, knowledge on danger signs, decision maker for obstetric care, emergency obstetric care, religion, monthly household income, these factors were significant predictors of the first delay. And this was similar to a study conducted in Bahida, where maternal age, level of education, monthly household income, and antenatal visit were significant predictors of the first delay. We also found out that 14.8% of women did not attend antenatal care, did not have any antenatal care during their pregnancy, and this was higher than what was reported in comparable study from Tanzania. So looking at the second delay, the factors that were associated with delay, we realized that the factors that were significant were still maternal age was significant, monthly household income was significant, and the mode of transportation too was significant. And for the maternal age, we realized that those whose age were less than 20, they were also at risk of delay in leaving home and getting to the hospital. This could be explained that majority of persons who are less than 20 years, they are not in the working class, they may not even have the money to pay for their transport to get to the hospital, and this will definitely lead to delay. And secondly, monthly household income, still those who are with household income less than 25,000 francs per month had a high risk of delay in getting to the hospital. And lastly, for mode of transportation, those who walked to the hospital, they delayed in reaching care than those who had their personal car or those who took a taxi to get to the health facility. So based on the second delay, we realized that 29%, 29.5 had accessible transport challenges and delayed in reaching a health care facility on time. And this was similar to findings by Awok and Selishi, where lack of accessible transport contributed to 30.2 of responses related to second delay. And this was similar to a study in Baida, that's in Ethiopia, where we found out that a greater proportion of those who delayed in reaching the health facility took at least 2 to 4 hours in getting to the facility. 55.5% of respondents in our studies used motorized transport. The rest had to walk, and this was higher than a study in Tanzania, where just 40.4% of respondents used motorized transport and others using animals, while others walking. We found out that low maternal age, low household income, and mode of transportation, that's mostly walking, were significant predictors of transport-related delays, that delay in access to health facility. However, in contrast to this study, the study carried out in Bahida found out that employment and educational status were significant predictors of the second maternal delays. Factors that contributed to delay in receiving care at the level of the health facility, that's the third delay. We still realize that maternal age was significant, and so domestic violence, women who had experienced domestic violence were likely to experience delay at the level of the health facility. But the most important predictor was still the maternal age, where women less than 20 were at risk of delaying at the level of the hospital. And this could be explained that women who are less than 20 are single, maybe they are not in the working class and could not pay for their bills and hence. And most often in our settings, if you are unable to pay for your bills, since it's more of out-of-pocket financing, if you are unable to pay for your bills, you are not attended to. So that's why women who are less than 20 could experience this delay, and those who were Christians to experience delays. And this could simply be explained that due to the fact that majority of the participants were Christians. So in our study, 58.6 delayed in receiving care at the level of the health facility. This was very high compared to a study in Ethiopia, where 30.7 women reported a delay in service delivery, and still higher than a study in Pakistan, where 48% of women delayed in receiving care at the level of the health facility. Maternal age was a significant predictor of the third delay, similar to studies conducted in Ethiopia and Rwanda, where maternal age and occupation were significant predictors of delay in service delivery. And this contrasts with findings from elsewhere in Ethiopia, where known demographic variables showed statistically significant association with the third delay. So based on our research, we found out that many women of reproductive age experience delays in emergency obstetric care, and that younger age, that's low maternal age, low household income, and not attending antenatal care were the main predictors of all the three delays. And we also found out that factors that influence delays were found to be interdependent and occur at multiple levels. So this requires multi-dimensional intervention that can take into consideration the challenges of the service providers and users' perspective. So based on our findings, we realized that even for the third delay, only the perspective of the pregnant women was sought out. And so we are recommending that a research can be carried out where both midwives and healthcare managers can be involved. So we also we recommend that provision of emergency transportation in the community level to the emergency obstetric care, that's provision of ambulance, it should be done. I just want to add that currently, because of what I found out in my studies, I'm currently carrying out the research on a framework for curbing delays in emergency obstetric care, where I'm looking at the perspective of the community, that's the pregnant women, that of healthcare providers, that the nurses, the midwives, the healthcare, and lastly, the healthcare managers. And I'm aiming at developing a framework that can be used to curb these delays in emergency obstetric care. Here are some limitations, and like I said, limitations: the sample size, only the perspective of the pregnant women was observed, and due to logistical constraints and insecurity, since these studies was carried out in a crisis-affected zone, so it was really difficult getting to certain areas. Here are some references. Thank you for your keen attention, and I welcome your questions.
Thank you, Dr. Tozi, for your presentation. Any question?
Thank you, and over.
Okay, thank you. Dr. Norgia?
Hello?
Hello?
Hello? Yes, are you hearing
We can
me?
hear you. Okay.
Slideshow. You don't see?
You can move
Oh,
on.
I'm sorry.
Slide, please.
Let me share my screen again. And now, are you see? Hello?
Yes, we can see.
Yes, we can see.
Yeah, okay. I was saying that this study was held here in Mozambique. I'm in Mozambique now. I'm Mozambican, but I studied at University of Pretoria. But now I finished my PhD and I'm in Mozambique. I'm Mozambican, and this study held in Mozambique in 2 districts, one in rural area and another one in urban area. The study was we used a structured questionnaire to ask the factors for foodborne diarrhea at the household. We include all the mothers who appeared at health facility with diarrhea, and we went to their house to see the house condition that can be a factors for foodborne diarrhea. And the data we analyze it mathematically using the info in order to analyze the data. The result, as you can see in this table, we found that in a rural area there are some children under than 6 months with diarrhea. That we think that in rural area, many of children have a diarrhea because in children under than 6 months, the mother used to give them a traditional medicine in order they believe that the traditional medicine can prevent some disease. Maybe the diarrhea appears because of that things. However, in a urban area, we found some cases of diarrhea because some of their mothers that did not breastfeeding the children. When we see the socio-demographic characteristics, we saw that most of the caregivers were unemployed and they have a low salary. Maybe that factor can be a factor for foodborne diarrhea because they no money to buy a soap to clean their house and have a good condition to prevent foodborne diarrhea. The other factors, social demographics we found is that the mother and the number of room. The most of houses that we visit will have only one room, but they have more than three occupied in the same room. That's why maybe if someone have a diarrhea in the same house, they can be a factor to transmit a diarrhea to the children, because if they don't wash well their hands, don't clean themselves well, then can be a factor to transmit diarrhea to the children. The other socio-demographic factors that we found is the house build material. The most of house they was built by cement. However, they are there are uh, the wall and the roof, they are still in cement. They can be not a cause a factor for foodborne diarrhea, but they can be a factor for a, a respiratory disease in children under 5. As we found in the previous study that we did, that most of children with diarrhea was appear with a, a respiratory problem, maybe because of the house condition, because their house they still have a sound and the walls are not well built in order to prevent a respiratory disease in children younger than 5. Other related factors we found is infant having before the mother went go to the hospital. We've seen that the most of the mother before they went to the hospital, they did not treat the baby. They not give a water. They not treat a baby with oral hydrated salt. Since they give some uh, uh, traditional medicine, maybe that traditional medicine they increase the diarrhea, because they when we saw where the mother stored the traditional medicine, we saw they didn't store it well, and they used the unsafe water to prepare that traditional medicine. We know that the WHO recommend that when you are going to the hospital, if someone has diarrhea, they have to drink water and other liquid to prevent dehydration for the baby. We saw that in this study, the most of mothers, they didn't give nothing to the baby until they arrived at the hospital. And the other symptoms that was accompanying diarrhea, it was a cough. Well, as you can see in the other slide, that most of the house was built with cement and without a wood walls. And possible source of diarrhea, we asked the mother and the caregiver what is the possible source of diarrhea. Some say that the possible source of diarrhea can be the moon, and they believe of the climatic change, the weather change, and other input that diarrhea with the food, fermented food, and that input for the other things. And although this, we saw that the mother doesn't know well what the real cause of diarrhea. We said when we ask when they bought their food, they say that they buy the food most of them buy the food at the market, and the type of infant food. Most of infant was eating fermented food, biscuit. That food is not really good for that infant, because when the baby has diarrhea, it can increase the diarrhea. And when we ask where they found their water for drinking, most of them, they have a tap water, whatever, but they use they don't treat the water for drinking. When we ask for the sanitary condition, we found that there are some there are some family in a urban area who
Dr. Norgia?
Hello?
Okay,
Hello?
we can hear you. Yes, we can
Yes,
hear
I don't know what. Yes, I'm sorry for that. My computer was down because we don't have electricity now, but I can continue in the conclusion. Sorry.
Don't worry.
In order to conclude, we conclude that it is important to the health provider to build a strategy, having in attention the family beliefs, because if you will build the strategy, we have the family contribution, we can fail on that. It is more important when we build a strategy to combat a foodborne diarrhea. It's better to involve the community in order to continue their strategy to appear the strategy. Okay, thank you.
Okay. Thank you, Dr. Norgia. Any questions to Dr. Norgia?
Yes, I have one question for her. I'd like to know.
Yes, please.
Why the biscuit given to the children are a source of diarrhea? Why do you consider that the biscuit given to the children are a source of diarrhea?
Okay, thank you. I say that the biscuit has a source of diarrhea because it